brushing your teeth, putting your shoes on. Over again. All the things in life that you can possibly do. Number 3. Left AFIR with bilateral arm reach. Left AFIR with bilateral arm reach will also promote mediastinum because your left hip is going back. I remember that yesterday. I'll get your question, Kurt. I remember that yesterday, Jonathan, when I had your legs go to the left. We call that right what? Trunk rotation. If I get right trunk rotation, that posterior mediastinum has to go back on which side? The left. I just kept you on the mat, kept your arms down, and just took your legs to the left. I could do it with a left adduction shift, another course, another day, another $1. But if you're now not going to neutralize the pelvis, neutralize the arms. And then shift the pelvis back into left AFIR. Rick.
You were talking about with the left arm reach inspiration.
Yeah.
As far as the right arm reach, what phase of the breathing cycle do you use?
Oh, good. And again, the question is, when would you bring the breathing phase cycle in with every one of them? Every time you reach forward, let's just take one, and they're all pretty much written out, just so you all know. You pick them, it's going to be written out. But let's just take one of them. Let's say I'm going to have you go forward with your left arm, just like she was doing. I'd start off, take a breath of air in, blow out, and what? You're going to see that a lot in PRI. Blow out and what? Reach. Hold. We did this yesterday, didn't we? Kurt's question is perfect right now. Didn't we do that yesterday? Blow out, drop the rib cage, hold. Then the left arm held it into a state of what? Exhalation, and you asked that patient to breathe. What was the right hand doing? Drawing it up. Since the right rib cage was on that forearm, as that person took a breath of air in, what was being expanded, Rick? Posterior mediastinum. So let's now apply that to techniques. Heather, I take a breath of air in. I blow out the air. I don't want to lose the sensation of that white terry cloth towel back there. On my next breath, in, feel the towel without moving that arm. Then you blow. I may say to the patient, don't let the towel go away when you reach forward. That's not on every handout. That's your decision. They may be able to do that just fine, and you don't have to worry about that towel in the next reach. Maybe you really want more AFIR with trunk rotation. Maybe, Jonathan, you really did not have enough trunk rotation that I'm happy with. I'm going to go after more what, Kurt? Trunk rotation. I'm going to go after more for you. I'm pretty sure you're neutral. Yep, you are neutral. We're going to look at those tests to tell me, Kurt, if his brachial chain is neutral. And if you are neutral, I can take a risk. We can drop off the towel when you reach. Kurt, that's $1 million question as a clinician. What decision-making processes are you using to maximize these two people? Did that help everybody? What are you doing? Go back and recheck. What about Kurt? What about this scenario? I have them reach forward with my left arm. They take a breath of air in. They blow out and they go a little further. It looks great on paper and it looks good on video. But I go back and I check, oh, poop. They lost their brachial chain. Did you do the technique wrong? No. You just allowed them to lose their posterior mediastinum with the technique they did correct. So what Kurt's saying, maybe go back, Tyler, and before you have him reaching any further that left arm, make sure they expand what, Rick? On inhalation before they start moving. Because the real problem is maybe they're not maintaining their brachial chain function because they didn't know how to maximize posterior mediastinum. I know how some of you feel about maximizing left AFIR. Why don't we get that attitude for posterior mediastinum? If you get that attitude for posterior mediastinum, I'm pretty certain most of your patients will be living on a farm, doing a lot of work without problems and harm. I'm pretty sure of that. provided they have a system that allows them to do it and no other problems, like trauma, surgery, infiltration. Does that make sense, guys? I'm pretty sure they can do it. If they can do it, they got to figure out how to do it. And Kurt's question is, what are you going to do on the arm reach? Are you going to maximize inhalation or exhalation? I don't know, Kurt. Kind of depends on the patient. I don't know. But the answer is, when you reach, you should be what? Exhaling. When you stop and you breathe in, arm doesn't move. Inhale. That, I think, is pretty clear in all the instructions. Excellent question. Excellent question.
There are some techniques where the arm does move forward, but it's really a direct result of your ribs moving back. And that's stated in the technique. It says, reach your arms forward as your ribs move back.
We will actually let you know when that is going to happen.
But it's in the handouts. If you look through some of those handouts in the back, you'll see kind of how those instructions are written.
Jen, thank you so much for, and that's left FR, so we just took the lower half, and we're putting the emphasis on the lower half now, not the upper half, but for the same concept. Same concept. Okay, here's a gal. Here's a gal who's got her back facing us, and we're looking at her, and the question mark is, what do you guys see? I see some posterior mediastinal imbalancing. What do you guys see? I know I know the lights are on. It's kind of hard to see. Can you guys see it? Susan, can you see it? Chad? Okay. Susan, let's ask you. Susan, what do you see? There's no wrong answers in this class. What do you see?
I see.
What's your gut say?
There's
First of all, yeah, go ahead.
shoulder imbalance.
Okay. But very good. I'll ask you a question. When you say shoulder imbalance, what do you see in the right shoulder versus the left shoulder? What do you see with this shoulder and this shoulder? Which shoulder looks more forward?
The right.
Okay, everybody see that? Susan says she sees the right shoulder looking forward. Well, you see less shoulder, first of all, the right. You see more shoulder on the left.
Yeah.
So you know the right shoulder's forward. Susan, keep going. I know she's got white on and the straps are, everything's... What else do you see on her? There's other things going on here.
Yeah, her spine doesn't look straight to me.
Okay, well, that's possible. What do you see about the spine?
Well, she's tilted.
Okay. Possibly tilted. Some of us would see it. Some of us may not see that. Some of us may see a little flatness here. Some of us may not see that. But there's something very obvious going on with this lady in light of the discussion we just had a few minutes ago. Let's go to your partner on the right side of you. Chris, what do you see? What do you see besides the shoulder, the spine? What else do you see?
I see a right rib hump.
Very good. Do you see this right side over here, guys? Do you see how her material is moving towards the left? Look at how she's busting through this side of her t-shirt. Look at this paravertebral column. Look at this thorax. Look at this. Look at the width of this muscle, and look at the width of this muscle. Her right middle trap, her right serratus, everything on the right side is a little bit more hypertrophic, a little bit more hyperdeveloped, used, more back, if that's okay to say it that way. So her right rib hump. We don't know if she's got a rib hump, do we, Chris? We don't know. And we don't really care if she does or doesn't. The fact of the matter, there's a person in the room that's not getting enough attention on this person. There's a person in the room that's not getting enough attention. His name is Rick. Right? Rick, what I see is what's lacking on this individual. Limited posterior mediastinal expansion on the left side. And the nice complement with that is the right shoulder, the right scapula is moving more forward on the thorax than the left, which means the right thorax is moving back on that same scapula more than the other side, which is why, Rick, there's someone that's not getting enough attention. I know right away, regardless of what we just discussed, Sonia, right away I'm going to put a band in her hand and start getting her to define what muscle. Serratus anterior. I don't care if it's for that or I don't care if it's for that. I don't care at this point. Do I? Because she's a right dominant creature on this earth. She likes her right hand. That's the norm. I don't see textbooks. Does she? She's in great shape, you guys. There's nothing wrong with this lady. I just said one day, can I get a picture of your back? It's perfect. Why is it perfect, Susan? Because it's a perfect reflection of mankind. That is a normal Tessa back. That's what I wanted in school. That's normal. That little asymmetry you're seeing, and it's not a lot, is it, Susan? We have to work at it. That little asymmetry I'm showing you, it's not a papa bear. It's not a baby bear. It's just normal. Normal. I would expect you to be a weirdo if that was reversed. Even left-handed people don't have left sides built like that right side. You'd be strange to me. I'd want to know about you. And if you were bilateral, that wouldn't be too abnormal. We see that a lot. Those are called bilateral brachial chain PC people. But because this is an introductory course, I want to make sure that you understand the question mark. There's nothing wrong with this lady. But please look at the asymmetry on your patients, and you'll see it. Which chest wall wants to come back? You don't have to answer the question. Ask yourself. I wonder how my patient's really functioning. Let's look. I don't have to look at the front. I'm going to look at your back. But I can look at the front because that rib hump on the right, we don't know if she has one. She probably has a little one in the front. On which side, Chris? It's called a flare. She's going to have a complemented flare right here. Little, not major, but if you look at her, you'll see it. And now we're talking about another word called rib rotation. Her rib rotation position is producing little minor torsional challenges. Little. The higher that rotational pattern, the more obvious it is. And what's the biggest obvious rotational pattern out there? Curvature of the spine. The more that curvature of the spine goes up, what is the torsional activity going on in that body? Higher and higher and higher. Which is why physical therapists, I hate to tell you, we're not doing a good enough job with scoliosis, because the research will tell you, the evidence is out there that you aren't needed. Physical therapy does not help scoliosis. Because the discussion we've had last day and a half is never considered. The discussion is centered around this thing called the spine. So all I'm trying to help you, and that's my opinion. That's only an opinion. My opinion right now would say, this is pretty normal. Does that make sense, Tessa? That's a normal looking back, which is why I like that slide. On page, what, Jen? 10? Page 10? Is that right? Or 11? Page 11 of the brachial chain. Or where is this at? Why am I confused? Oh, that's right. That's where the muscles are. I'm going to go over some muscles real quickly, and then we'll take a little break, okay? So the muscle pages are earlier in the textbook. We're going to go back to a few, okay? So we're going to talk about muscles. And the muscles that we got to be concerned about are the ones that are listed in your BC tab, the deltoid, the lateral intercostals, Simpsons we talked about this morning. Yesterday we talked about a muscle called the triangularis sterni. Today we're going to talk about a muscle called the sternocleidomastoid. And we've been talking about the diaphragm from day one. But these scalenes and SCMs, these are the muscles of the brachial chain. The scalenes raise. Just underline the word raise. Go back to page 11, circle the word raise. Scalenes lift. They're lifters. They're raisers. They lift. They come off your neck. They attach to your ribs, first, second rib at the most, and they raise. They raise. All three raise. Raise. That's all you got to remember about scalenes. Now, when I do this, sniff, I'm going to use them. I'm very thankful. As my torsion goes up, to have them, by the way, as my torque goes up on my body, as my need for power is generated, I pull in accessory muscle. The top accessory group I'm going to pull in are called scalenes. Not to breathe, but for control, stability, and Valsalva positioning. So as I do things, Carrie, whether